thank you for joining us today for implementing behavioral health evidence-based practices for justice-involved individuals. Really appreciate you all being here today. My name is Katie Garrett. I'm a project associate at the Council of State Governments Justice Center. I am sure I have either spoken to all of you on the phone or emailed you in some way. My apologies for clogging up your inbox if that's so. But really glad that you all are here, and I hope that for those of you I haven't had a chance to meet face-to-face, that we get a chance to throughout the conference. We have a great panel with us today. We're going to start off, I'm going to do some panel introductions, and then our panelists are going to go through their presentations, and then we're going to have some time at the end for some questions. So our first presenter is going to be Dr. Roger Peters. He's a professor at the Department of Mental Health, Law, and Policy at the University of South Florida. After Dr. Peters, we're going to have Stephanie Ainsworth, who is a research assistant at the Center for Advancing Correctional Excellence at the Department of Criminology, Law, and Society at George Mason University. Following Stephanie's presentation, we're going to hear from Glenn Tapia, who's the Program Director of the Office of Community Corrections, Division of Criminal Justice at the Colorado Department of Public Safety. And following his presentation, we'll hear from Amy Seidlitz, who's the Chief of Offender Classification and Programs at the Washington State Department of Corrections. So again, appreciate you all being here today, and we will go ahead and start with Dr. Peters.
Thanks, Katie. Appreciate it. Hello, everybody. How are you doing today? Good afternoon. It's great to be here this afternoon at the conference. A lot of good information, great panelists, a lot of expertise out here in the room and on the panel. Looking forward to hearing about their experiences as well. Katie asked me to talk about a couple different topics to get things started this afternoon. We'll start out with a little bit about screening and assessment, including risk and needs areas related to mental health, substance abuse, criminogenic risk. Talk a little bit about that, some ideas about what types of practices you might consider that are evidence-based. I know a lot of you are using different types of needs and risk assessment instruments, and we'll talk a little bit about those. And then I had the daunting task of addressing best practices for treating substance abuse and co-occurring disorders, which is probably the topic for a couple-day workshop at least. And then tailoring treatment strategies, which is another area that would warrant a considerable amount of time, right? So I'm going to touch on just what I think are some key themes, and I'll defer on the second area to some conceptual models that I think are useful, including the R&R model, cognitive behavioral treatment, and social learning model. We'll talk about some of the themes and similarities between those models, and some specific curricula that you might look at. I mentioned that in the morning workshop, so there's a couple of you left over from the morning workshop. I apologize in advance to repeat that information, but I think it's important for people to have a set of ideas about what's out there that you might consider. And then tailoring treatment strategies, we'll be talking about how do we address evidence-based practices with different subpopulations. And we'll just talk pretty briefly about issues related to gender-specific programming, co-occurring disorders, criminogenic aspects, criminal thinking, some different things to consider. So with that in mind, we'll go forward and preaching to the choir here. I think people are pretty much sold on the idea, I hope, that we have an important task ahead of us for screening and assessment of offenders for the reasons I think laid out here. Very high prevalence rates, right, of these disorders, much higher than the general population, 4 to 8 times the rates of the disorders for both mental health and substance abuse. So really, there's very few people that don't have substance abuse disorders. For example, 80% of our offender populations. On the mental health side of things, 15% of males and 31% of females have bona fide Axis I disorder. So a big need to provide universal screening for those disorders. We'll talk about trauma and PTSD as well. I think that should be a universal screening in all of our programs, given the high rates, not just for women, but for men as well. Rates as high as 50% in your populations, I'm sure, of a history of violence, trauma, PTSD. But certainly having this information in front of you allows you to do some things that you couldn't do ordinarily, right? Which is to quickly link people in, fast track them into services, and particularly specialized programs for people with high risk and high needs. People that otherwise wouldn't do very well in our treatment programs. For example, women that have a history of violence and sexual abuse aren't going to do very well if they don't have those needs addressed right up front. So something to consider. People with these disorders that aren't detected and aren't placed in appropriate services, we know what happens to them, right? They're the statistics that make your programs look bad. they cycle back through the justice system, through all of our social service systems, emergency rooms, and so forth. So we have to do a better job in dealing with these populations through identifying them early, matching them to services. Matching is the key aspect, I think, and it's the new frontier that we're going to be looking at in the next 5 years, 10 years, how to better do a better job of matching based on risk, needs for substance abuse, needs for mental health, and other related services. We do know that meta-analyses showed that programs with more comprehensive services, such as comprehensive assessment services, do a better job in terms of their outcomes. So we have pretty clear evidence of the importance for these activities. So in a few brief minutes, I'm going to share with you what I think are some evidence-based instruments. What are some evidence-based instruments in both mental health and substance abuse, and also trauma, PTSD. Start out with just a concept for you, is that not all instruments are created equal. There are some, and this is not, I'll get into risk assessment a little bit later. I don't think it's the case with risk assessment instruments as much as with mental health and substance abuse instruments, but not all of the mental health and substance abuse screens, for example, are created equal or equally valid, equally useful for different subpopulations, and we'll talk a little bit more about that. But I won't go into detail on these particular instruments, but these are all validated for use with criminal justice populations, have good evidence with non-justice populations, are reliable, valid psychometrically, and are also, for the most part, public domain instruments. The GAIN is the one exception that has training costs associated with it, but also a very good instrument that's used a lot by grantees. People using the GAIN here in this room? I think it's the SAMHSA grantees that use that mostly. But in any case, these are very quick to administer, don't require a lot of training, easy to score. And some of these are available. The Brief Jail Mental Health Screen, the Mental Health Screening Form 3, and the Mini are available online. So very easy to access as well. On the substance abuse side, the same basic message. There are some good public domain instruments available. You should be using these if you're not in your programs. There's a lot of programs that are just using homegrown instruments, and there's a danger to that because you either will over-identify people in your programs that don't need the high-end services that you're providing, or you're going to under-identify people. And it may just be a few people that don't get identified, but those could be critical people that aren't linked to services immediately. So the one thing I like to mention to people, there are some instruments out there that are commercially marketed, like the SASE, that are not particularly good and that have poor psychometric properties and that do a pretty poor job of working with subpopulations like juveniles and ethnic minorities. So be careful about that. Just a caveat, we aren't always aware of that information. They don't want you to know that information. They're up front at conferences trying to sell you their instrument, which is the most expensive about the most expensive substance abuse screen that you can buy. Anyway, so just a caveat about be careful about the instruments. Any one of these would be, I think, very useful for your programs. The ASI you're familiar with already. As I mentioned, the GAIN. The TCU screen is available online, very brief. Simple screening instrument available online as well. It was part of a CSAT tip document years ago, but it's still around. We actually just have a paper coming out on the psychometric properties of the SSI with a Medicaid population, 6,000 some people, good properties. So any one of these I think you do well to use. On the assessment side, these are some instruments I just thought I'd share with you that I particularly like that are basically free of charge. Again, has some training expenses along with it, but the ASI, of course, you're familiar with, and the Texas Christian instruments you may not be as familiar with, but they're available online at their wonderful website. The Institute for Behavioral Research at TCU has all kinds of treatment manuals and screening and assessment instruments for all different populations and needs, including criminogenic thinking, juvenile populations, adult populations, and so forth, but particularly focusing on substance abuse. So these are instruments that I'd recommend looking at for in the assessment area. And of course, these address mental health to a certain extent, but they don't do a particularly great job of looking at mental health issues. So if you're looking at co-occurring disorders, this isn't the answer to your mental health evaluation. And there's a lot of other instruments out there that you're probably familiar with in the mental health domain. The PAI, the MMPI, the MCMI come to mind in terms of psychological assessment, objective measures. for diagnostic purposes. The SCID and others are good measures for that as well. I didn't provide a slide, and just backing up to screening for a second, I didn't provide a slide on screening measures for PTSD and trauma, and I probably should have, because I really firmly believe that that is part of the triad, along with mental health and substance abuse, that needs to be part of your arsenal. And actually 4 pieces, the risk assessment. But there are a lot of good instruments out there for PTSD and trauma that I would highly recommend. I've worked with the Justice Department to recommend some additions to their ADAM program, the old DUF program, for providing screening of new arrestees and providing drug testing in jails. And the instruments that I recommended, I'll recommend to you as well. The primary care PTSD screen, PC-PTSD, is a 4-item screen. Tracks really well onto markers of PTSD. And then the PTSD checklist, the civilian version, 17 items that corresponds to the symptoms of PTSD. And again, PTSD is a proxy for trauma, isn't it? It's what we use to kind of screen for trauma for the most part, until you get into a real heavy-duty assessment. So anyway, I just thought I'd share with you a couple ideas about those kind of screens as well. And think about that in terms of the high prevalence rates and how it might add to what you gain in terms of information about triaging people into services based on that information that doesn't take a lot of time to administer and gather for your programs. So just moving into risk assessment for a minute, and again, I apologize for moving quickly, but I want to get on to the other panelists and just provide an overview of some of these issues for you. Risk assessment, how many people are doing risk assessment in their programs? Good, most of you are. I won't call on you. This is a really important process, and we're gaining more. This is probably the last area that we're really learning about in terms of assessment that's important and how to do it. And there's some new instruments that are emerging. And I have a slide that shares some information about those instruments. Again, the focus of risk assessment is to target the highest risk cases, right? So you can triage people into your resource-rich programs that really deserve that treatment. And we know that people that have higher risk levels have better outcomes in your programs, whereas people with lower risks, sometimes, for the most part, they have worse outcomes because they weren't at risk to start with. So when you provide any kind of intervention, it has about the same impact, and you're not using your resources very well with that group. Also, you can lead to poor outcomes with that group and actually increase recidivism by providing more intensive interventions that are needed, if that makes sense, for that population. So really important to reserve your time, attention, resources for the high-risk cases. Risk assessments really targets this middle area, the criminogenic need. So all your risk assessment instruments will look at dynamic factors, and we'll look at that in just a second, which are factors that change over time that you can impact in your programs, in your substance abuse programs, your mental health programs, other supervision, correctional programming. And then responsivity is the third part of this R&R model, risk need responsivity model. And that basically just means tailoring programs to allow offenders to respond most effectively to your interventions. And that means for somebody with co-occurring disorders, you're not going to give them a cookie-cutter substance abuse program. It's going to focus on the interaction between mental health and substance use disorders, right? For female offenders, it means just what we talked about, dealing with trauma and abuse, so that they're not getting a cookie-cutter approach that doesn't address the gender issues and doesn't provide specific programming with female counselors and special gender-sensitive issues in the treatment and special groups just involving women. So just a note about the overall model. We'll come back to that in a minute. But in terms of risk assessment, then, we talked about this middle area being the core of those assessment instruments. And here are the factors, again, that are comprised in the risk assessment instruments. Again, all of these are factors that can change over time. One factor that's not on here that's part of risk assessment instruments as well is static risk factors, which are basically historical items or demographic background items that can't change. So age at first arrest, and probably the most important one, which is, anybody? History of criminal activity, which is the most important predictor of future behavior, right? It's always past behavior. So we learned that in grad school pretty early on. So that's not on here, but it's part of all risk assessment instruments. These are the need areas that treatment focuses on. You can't focus on history of prior felonies or age at first arrest. You can focus on these things, which are dynamic and change. What's not on here is mental illness, right? Not to say that that's not an important factor. In fact, we'll look at this in just a second. People with mental illness have a higher number of risk factors than other populations in our offender groups. But having a mental illness doesn't mean that you're more likely to be violent, more aggressive, or isn't independently related to the risk for recidivism. In other words, it's because people share a lot of other risk factors who are mentally ill that any other offender might have as well and create a high risk for recidivism. So we look at that, at the overall picture for a second in terms of targeting these criminogenic needs that a risk assessment instrument would look at. So a risk assessment instrument would allow you to look at these different areas of needs, identify people with the greatest number of these needs, and then hopefully in your programs, you'll provide corresponding services to address those, right? Employment, family issues, leisure skills, substance abuse, criminal thinking, all of those areas, and others, leisure skills. So as you get to the left-hand side of this graph, you see programs that address more of the criminogenic needs that were just listed. And you see that you have much greater impact on recidivism. Whereas on the right-hand side, programs that don't deal with as many of those criminogenic risk factors have less of an impact on recidivism. And it's a linear function. Every single step as you go left is lower and creates a more impact on recidivism. Every step to the right, as you decrease the number of need areas that are addressed by the programs, leads to a less of a decrement in recidivism. And even here, at the very far right, you'll see that they increase recidivism. So you can have a negative impact on programs if you address non-criminogenic needs, right? And there's a whole bunch of programs out there that do just that, that focus on non-criminogenic needs. It might be sensitivity training, or might be building assertiveness, which is a need for co-occurring populations, but not typically for offender populations. Self-esteem is another area, that kind of thing. All right, so here are the instruments. And again, I'm moving quickly. I can field any questions for you that you'd like afterwards. But the good news for these instruments I mentioned before is they basically perform about equally. They're all about equally well in predicting recidivism. And the reason is that they all address the same kind of criminogenic need areas. It's not rocket science. And there's not a lot of mistakes made by these. They're usually empirically derived instruments, which means they take these sets of items that we just talked about, put them in an instrument, and then test them out and validate them. And lo and behold, they all come out about the same because they're looking at the same areas. And that is the criminal history and the same dynamic needs that we talked about. So a couple of these are not familiar to you probably. The HCR20 may not be. The START instrument may not be familiar. Those two are perhaps the most used internationally of any of the risk assessment instruments, believe it or not. They're not used as much in the United States, although in the panel this morning, somebody from New Hampshire, I believe, was using, no, it wasn't New Hampshire, one of the other states represented was using the HCR20. Very good instruments, but again, most of these perform about the same. The RANT instrument is a very short dichotomous screen looking at high risk versus low risk offenders that was developed for drug courts but can be used in other settings as well. It's probably a little shorter than some of these others. The LSI-R is probably the most familiar to you, is also probably the longest and the most costly of all of the risk assessment instruments, but I think tends to do a good job, and the data is quite good on the LSI-R as well as these other instruments. So let me transition then pretty quickly to evidence-based models of practice. The several models I'd share with you, I think, are pretty clearly evidence-based. We just talked about the R&R model that has a good base of evidence. Cognitive behavioral treatment has four different meta-analyses related to offenders that show that CBT is very effective. Significant reductions in recidivism that range to about 25% during a one-year follow-up. The greatest effect, no surprise, is with higher risk offenders. One surprising finding from meta-analyses is that the different programs that are kind of commercially available or packaged they don't vary a lot in terms of the outcomes. So the good news is, just like with the risk assessment instruments, if you pick one of those, you're pretty likely to have a good outcome in terms of use with offender populations. They're about equally effective. Social learning model. Again, this deals with more of the criminal thinking aspects, and TCs, therapeutic communities, peer learning, feedback, behavioral techniques that provide a chance for skills-based training, learning, rehearsal of those skills, and so forth. That model is pretty much blended with cognitive behavioral treatment in a lot of our settings, isn't it? And but the meta-analyses show pretty significantly with offenders that you have very good effects in reducing recidivism, particularly if you focus on antisocial attitudes and values and beliefs. So I'll be plugging criminal thinking curricula to all of you to add to your programs if you're not using those. How many people are using a criminal thinking intervention? People are nervously not raising their hands, thinking that we're going to take names. There's some common features, though, of CBT and social learning models. Here they are. I won't go into a lot of detail, but they are skill-building focused. They use, as I mentioned, behavioral techniques of role-play, rehearsal, modeling, feedback, and so forth. A lot of repetition of material for our population, behavior modification approaches, such as contingency management, contingency contracting. Some of you are familiar with that. Dealing with cues for relapse and other techniques, some of those things. Interpersonal problem solving. Very important, and we know that dealing with negative emotions is a really big relapse predictor for offenders. So dealing with conflict, whether it's a spouse, friends, colleagues, peers, really important for this population. But in general, identifying problems, brainstorming solutions, coming up with a sequence, a logic sequence about how you solve problems. It's really a process that offenders can learn and benefit from by these approaches. And it's similar to cognitive behavioral treatment, right, CBT, where they learn to restructure their thoughts. And it's a tool that you teach them once and they can apply it to and generalize to all different parts of their life. I remember when we developed our jail program in Tampa, we talked to offenders, kind of debriefing after the program to see how they liked it. And they loved the fact that they could actually use it outside of treatment in all different settings, at home, to deal with anger, problem situations, and so forth. And then finally, the cognitive strategies to address criminal thinking is built in within social learning and CBT as well. And there are a number of curricula that I'll recommend in just a minute to address these. So those are some of the models that I think just a big picture piece of what you need to be looking at within your programs inside the black box. So what works in 5 minutes? There's a range of strategies for behavioral health that I think there's an overlap in terms of strategies that work for co-occurring disorders and those that work for substance abuse issues with offenders. I think we talked a lot about cognitive behavioral treatment already. There's a number of manuals that we'll get to in just a minute. I mentioned contingency management, motivational enhancement. I think a lot of you are familiar with motivational interviewing, those strategies. Again, good meta-analyses on that with offenders showing that it's very effective, reducing recidivism by, I think, 15 to 20%. There's one group it doesn't work well with. I think it's DUI offenders. Relapse prevention provides a common vocabulary for your probation officers, parole, treatment staff, judges, others. It's a great tool. Also, as you know, works really well with co-occurring because you're looking at common relapse triggers and common set of thoughts, patterns of behaviors that affect both the relapse to substance abuse and recurrence of mental health symptoms and disorders. Trauma-focused treatment, a number of those, and we'll share with you some information about the curricula in just a second. And then these other areas for co-occurring, I talked this morning in the session a lot about integrated treatment, and we'll share with you some of the treatment manuals for that as well. But good news, I mean, we have some really good evidence-based curricula in each of these areas that you can apply in your programs. There are other kind of interventions as well, though. Supported housing, supported employment have a really good database. Family psychoeducation has a really good database for co-occurring disorders. And also in substance abuse programs, the evidence shows that family involvement is really, really important. Sometimes hard to do in your settings, depending on if people are in prison or incarcerated settings. Modified TCs, good evidence about those impacts, right, for substance abuse as well as co-occurring disorders. You have programs in Colorado that have shown great impact for TCs in the prison and outside the prison, and the combined effect when you provide both together is a cumulative effect in reducing recidivism. So lots of good practices. Encourage you to get out there and look at some of those really carefully if you haven't looked at the curricula that we'll share with you in just a minute. So just a couple ideas about tailoring for different populations that we've talked about a little bit so far. And these are some of the populations that really, in terms of responsivity, that part of the R&R model, where you need to create better responsiveness for offenders to the interventions you provide. These are some of the areas that I think we fall through the cracks in terms of not addressing as well as we can, and again, targeting through screening and assessment who actually needs these services. These are people that are going to have higher rates of recidivism if you just provide them a stock treatment approach without providing tailoring. We know the high rates of mental disorders, poor outcomes in your treatment programs without specialized interventions. And the good news is that adaptations are out there. There's specialized curricula. In prison and jail programs, for example, you have longer duration of treatment, right? Heavily structured, intensive programs. They have less confrontation, more support generally, less peer-driven activities, more professional staff organized activities, and a whole litany of other kind of areas that you could look into for adaptations. We just finished a national survey of court programs, drug courts, mental health courts, special dockets for co-occurring disorders, and looked at some of the issues there and how they adapt for this population. Very interesting. And some of the adaptations are things like judicial hearings are quite different. They're smaller, less of a large audience and a small group of people. The judge comes down from the bench, takes off his or her robe, talks informally with the individuals to make it a less threatening environment and so forth. So very interesting adaptations that are successful in implementing some of these programs. History of trauma and PTSD. I mentioned before that this is high base rates of these disorders in our populations, right? I was shocked in our jail program when we did the ASI, and we did like a couple thousand ASIs administered to men and women. The men were coming up with rates of 50%, self-reported rates of violence and history of trauma. Women, 75%. But I was shocked at the men, at the rates, and that's, self-reported offenders who don't often talk about these things. So big need for these interventions for both men and women. We had Lisa Najovitz down talking about seeking safety in Tampa a couple of years ago, and she was just in the process of developing manualized interventions for men, but and for offender populations. And as you know, unless these types of problems, particularly trauma and PTSD, are addressed, it undermines the success in your standard treatment. So you really have to be able to address that. Criminal risk, I've again mentioned this already. We really need to provide these interventions. This might be the biggest single gap right now in our programming, I think, in substance abuse programming for offenders, is just addressing the underlying beliefs, attitudes, thought processes of offenders through cognitive behavioral treatment interventions and through the social learning models, the feedback, confrontation about criminal behaviors. There are whole TCs that are based on addressing criminal thinking. And most of the TCs now, I think, focus on that as a big part of their interventions. But there's something like 30 different criminal thinking patterns. Samenow and Yokelson, you guys are familiar with some of their work. A lot of the TCs are based on those, or have groups that are just focused on how to address those thinking patterns. So we really need to ratchet up our interventions based on criminal thinking, and there are evidence-based protocols available that'll be on the next slide. Other populations that need specialized adaptations and attention as well, in terms of, we talked about female offenders, cultural, racial minorities. Not as many good, I haven't seen a lot of good curricula that talk about either training staff or adapting interventions for different cultural, racial minorities. I just haven't seen it. But so there's a big, at least at minimum, there's a big staff training need in that area. So here are some of the curricula I'd share with you, and these are both for co-occurring disorders and criminal thinking and substance abuse. And I'll share some information about just regular substance abuse curricula as well. And I don't have time to go into detail on these. The IMR program, highly recommend you look at that. It's available online. It's free of charge. It's part of the Center for Mental Health Services Toolkit. If you go on their website, you can find the entire batch of materials that has training videos, has modules for presenting in treatment, very useful skills-based approach that use a lot of relapse prevention, tailoring for medications and behavioral issues related to how you get people to adhere to medications and so forth. The second curricula I really, really like is a integrated group therapy for bipolar disorder and substance abuse. Don't let the bipolar disorder shake you there. I think that manual can be adapted for any of our populations with co-occurring mental health disorders. It developed at Harvard by Roger Weiss and his colleagues. 12 sessions can be adapted for a little bit longer. You can split those sessions up. Good outcomes from NIDA-based studies of outcomes. Highly recommend you look at that. You're familiar with Seeking Safety, probably. It's one of the interventions for trauma and PTSD. And then the good news also, we have the curricula for criminal thinking. And these have been used for years in Canada, other places. The United States have come to those recently. Some of the leaders in the states, states like Colorado and Wisconsin, Minnesota, and some of the others have used these for years as well. Good outcomes, evidence-based curricula, and I think these are all free of charge. Except for criminal conduct and substance abuse, which is a manualized. You can buy that for something like $20. I don't know if it's Guilford Press, but it's a low investment there. And then there are curricula as well for trauma and PTSD and substance abuse. I didn't mention there are obviously a whole range of curricula just for substance abuse treatment and evidence-based curricula. Living in Balance is one. The Federal Bureau of Prisons has a curriculum, and I know they incorporate different elements, but that's a public domain set of materials. The Bureau of Prisons has materials that you might look at that you can use in your programs for free. So I don't know that they disseminate those. They're not at all of these conferences where they share that information, but be worth looking at. Group therapy for substance abuse disorders, cognitive behavioral approach for treating cocaine addiction, some other examples of curricula that are out there that are evidence-based for our populations. So a range of different things that are out there that you can take advantage of. I encourage you again to, we don't have time to go through the nuances of all of these programs, and they're quite different with some overlap. But I think in each of these areas, the key is to create a menu of these programs, and perhaps you can have tracks in your programs that address some of these special needs, such as criminal thinking for people at the high end of risk, and for things like PTSD and trauma for women particularly, but also for men that have that history. Great, I'm going to end there. Thank you very much. And again, you have my email and probably a phone number in the packet. I apologize, I'm not going to be able to stay around, but if you have questions, be happy to address those.
Hi, my name is Stephanie Ainsworth. I'm here today from the Center for Advancing Correctional Excellence at George Mason University. I'm a third-year Ph.D. student, and I'm filling in today for Dr. Faye Taxman. She has a long history in the implementation sciences, so if I don't quite adequately cover anything today, feel free to contact me or her, and we will get all of your questions answered. I'm going to start off not actually with this slide, because Dr. Peters did a great job of covering just about everything on this slide. It's just kind of the transition from one to the other. My presentation is actually going to focus on, I'll backtrack here, readiness, fidelity, and quality assurance. So now that we know what needs to be implemented, those evidence-based practices, I'm going to focus on how you make that happen, how you assess what you're currently doing, and how you promote sustainability for what you have going on already. And I understand that people are at different places in their process of implementation, so hopefully I'll touch on a little bit of everything that you guys have going on for wherever you are in the process of implementation or sustainability. So first, we have all of these evidence-based practices, but research shows us that unfortunately, even the large number of evidence-based practices that we have, less than a third of them are being adopted. So there's reasons why, even with the knowledge out there, why agencies are unable to adopt certain evidence-based practices. Movement going on for you. It's a balancing act. There's a lot going on within an organization. There's a lot of external influences on an organization, and there's a lot of moving pieces there. So the idea is to balance all of the moving pieces in order to implement these evidence-based practices in the most effective way possible for your agency. So we're going to look at external influences and internal influences. First, we're going to talk about readiness for change. And I will preface this with all of the areas that I'm going to talk about here. We do have measures that we can share with you, either that we've created or that we've pulled from other places that we've collected over the years, that we can share with you if you're looking for something to assess your individual organization for any of these items. So first, we want to look at external measures. The environment is key when you're looking at external measures for implementing change. Your agency does not work in its own little siloed system. You guys work with other organizations. So it's important to understand what the environment has going on, how your agency fits into that environment, and how that environment is going to impact your agency. It's also important to look at external resources. So you can conduct a resource assessment to see what resources externally are available for you. Whether it's grant funding or other opportunities, you want to be aware of everything that's out there because it's all going to help in your toolbox to implement these evidence-based practices. You also want to contact key stakeholders within the field. These may be community groups or other people that can be in your corner, and if you don't contact them, they might hinder the process instead of help it. So you want to bring people on board who can help with the full implementation and use of the evidence-based practices. I'm going to get a lot more into the internal measures here, slide by slide, but you can see here that there's a lot as far as the internal measures that you want to be aware of. So this right here, we're talking about cohesion, involvement, hierarchy, consistency, innovation, adaptability, and performance achievement. Basically, you have different levels of focus and structure within an agency. It's important for you to understand where your agency fits within one of these quadrants because it reflects either internal or external focus or flexible or stable structure. There are ways to implement evidence-based practices regardless of which combination of these that your agency embodies. But it's important to understand what they are to know how to move forward with implementing evidence-based practices. Looking at resource assessment, there's a lot of things that you want to be looking at as far as staffing, retention, training and skills, and funding. You want to make sure that you have adequate staffing to be able to implement whatever evidence-based practice you're looking to try. A lot of you guys already have risk assessment instruments in use. You know that it's a lengthy process. Even if you're using a screener, it takes time. You want to make sure you have adequate staffing. You want to make sure that you have people who are trained to use them and can coach others in the use of these instruments. Retention. Training itself takes a long time to do any evidence-based practice, so you want to make sure that you're keeping people in the agency so you're not training them and then they're immediately moving elsewhere, because then you're going to retrain and you're losing time and you're not going to be able to implement whatever practice it is. Training and skills, I've already touched on this twice, just talking about two other areas. Training and skills permeates every area for implementation of evidence-based practices. It needs to be made a priority for the organization, and you need to continue to have follow-up trainings. Evidence shows us that one-time trainings are not the most effective, that people lose sight of the goals of the training over time. They need refreshers, and they need internal coaches to help them refresh on these practices. Funding is always an issue. People always gripe about funding, but you need to be aware of your funding limitations. Be realistic within your agency of what funding you do have. Look for other sources of funding to see what else might be available, and use what you do have available. Don't try and go beyond your means, and use what you do have wisely. Physical facilities. This is oftentimes a big problem for people. You just don't have a place to train people. You don't have facilities to offer services to people. It's something that you want to assess your agency for at the get-go, so that way you are aware of the barriers that you might come across when implementing an evidence-based practice. You can't say that you're going to hold on-site trainings if you don't have access to a conference room even to host a training. So it's just things to be aware of. Computer and IT, one of the great things to do if you can't do conference trainings or such things like that. Maybe you can do a web-based training, but not if you don't have the appropriate software or IT services. You also can't be doing online assessments or expect individuals within an agency to be looking at online resources if they don't have adequate computer access or access to any of the great resources that were talked about just a minute ago. You also want to look at integration. One of your big resources is using connections that you have with other agencies that are already providing services. If you can connect with them, you can use your resources more wisely to create seamless systems of care and not tap out your own resources. And community support, I talked on this earlier. This gets back to one of the external influences as well. You really want to see what community support you have to help supplement your own services to help promote the use of evidence-based practices. So next we want to look at commitment, fit, and cynicism. These are all things that can also go under organizational climate. You need to be aware of your staff's commitment levels, their fit with the organization, and their cynicism towards change. All of these can present as barriers to change. If staff don't feel committed to the organization, or if they don't feel that the organization is committed to the organizational goals, if there's a mismatch there, you're going to end up with some very frustrated people who are trying to implement practices or refuse to implement practices because they see this large disconnect. People might not even be aware of it, management might not even be aware of it, but it might exist and it can limit your ability to implement practices. Same thing with fit and alignment and cynicism towards change. Cynicism especially you want to look at, there's been research that suggests that individuals who have been with an agency longer get into a groove and want to continue the practices that they currently have going on, and there can be cynicism towards change. A lot of times it's a misunderstanding between what you're asking them to do and what they're currently trying to do. There's a slight fear of new learning, new training, that they might not be able to do some of the new things that you're asking them to do. But a lot of times all of this can be changed within the appropriate training as long as you're aware that this is a barrier to change that you might come across. And like I said, there are assessment instruments available for all of these areas, and it's important to know where your agency stands before you try and implement any evidence-based practice. And that's regardless of whether you've had successful implementation in the past or not. You might find that one EBP is a lot easier to implement than something else. So once you have them implemented, then what do? You assume that everything's all hunky-dory, we got our risk assessment instrument going, then all of a sudden it starts falling off and you're not sure what happened. Fidelity is crucial at this point. You really want to understand the degree to which the innovation was implemented as intended. Are individuals saying that they're doing a risk assessment instrument, but really they're not doing it? Are they doing it as they've been trained to do it? Or are they doing it with a lot of overrides for unsubstantiated reasons? It's things like that you need to understand if the evidence-based practice is going to work and continue to work within your organization. This is also crucial because a lack of fidelity in implementation can actually mimic lack of effectiveness of an evidence-based practice. So a lot of times if people don't assess for fidelity, they may incorrectly assume that an evidence-based practice does not work for them, doesn't work for their organization. It may be true that within the specific set of circumstances that you have, that an evidence-based practice might need to be altered, but you won't know that and won't be able to tell the difference between that and a lack of fidelity if you're not measuring fidelity. Ways to measure fidelity, there are 3 core areas here. You really want to look at knowledge transfer. Did the evidence-based practice training that you just went through or the implementation that you went through change knowledge? So you want to look at the extent to which respondents understand the core components of each evidence-based practice. Then you want to look at behavior change. It's not just enough, it's the same thing when looking at an offender population. It's not enough to just change thoughts, you also want to change behaviors. It's the same thing with staff. It's not just enough to teach someone the importance of a risk assessment instrument, you also want them using it. So you want to assess for those 2 areas. You also want to assess your organization's ability to sustain the evidence-based practice. So is it one of those things where you do need someone to come in and provide refresher trainings on something? How often? Where's the drop-off point for your organization? At what point do you guys need the refresher or not at all? Things you won't know unless you're actively measuring and repeatedly measuring for these items. So there's also a difference between evaluations. You have your program evaluation and your process evaluation. Within the program evaluation, this gets back to the effectiveness versus fidelity problem again. Effectiveness of the innovation relies on the implementation of the key principles of whatever program you're implementing. So there are core principles to every evidence-based practice, and you really want to evaluate if you were able to implement those core principles. Then you also want to look at adherence to the implementation plan, why or why not the implementation did or didn't work, and how was the intervention implemented? Did the core components appear or not? And it's important to remember that with a lot of these items, especially the second two under process evaluation, it may require more than just survey instruments. It may require people to go in and observe what's going on, so that way you can reflect upon practices instead of just getting self-reports of people writing down staff saying, sure, I do this, sure, I did it that way. It might be behaviors that need to be observed. So getting into quality assurance, you're pretty sure you have things implemented well. They seem to be going. You've been using your instrument for a while now. How do you continue to ensure that you're having quality use of the evidence-based practices that you've implemented? One of the biggest curricula out there is the PDSA curricula, which is the Plan, Do, Study, Act. It's a team approach to improving performance where individuals identify their own barriers and obstacles and focus on rapid cycle, short-term changes. So you want to clarify goals, address barriers to change, and move forward. How do you do this? You want to set benchmarks, which is just small goals that you want to achieve using a risk assessment instrument that you want to start out small if you're just starting implementation, and you want to have maybe 30% of your offender population using or being screened at first. Once you achieve that goal, to achieve that goal, you identify actions. What's required to achieve that benchmark? Then you review the process. Did it work? Did it not work? Did it work within the time that you allotted? And you have to be realistic. You have to understand why it did or didn't work. And then when you're done, repeat the process, either with the same evidence-based practice or move on to the next one. So all the time, this should be within 90 days or so, you repeat the process, creating new benchmarks and sustaining prior benchmarks. So once you've moved on to the next EVP, don't forget about the ones that you've already implemented. You want to continue to improve upon the processes that you have going on. Finally, there are resources out there. Like I said, there's the instruments. There's a lot available in Dr. Taxman's book. There are more available through our center. And we also have a really great website that we're starting up very soon where you can rate your program's jurisdiction, among other things. So you can take the services that you currently are using, the programs that you're using with your clients, and you can rate them to see, are they using a treatment manual? Are they reflecting evidence-based practices, or are they just going by the name? Because you could say a drug court is a drug court, but just giving it the name of a drug court doesn't mean that it has the core principles of an effective drug court. So using some of the tools on this website, you'll be able to assess your program and assess its fit with your population to see if there's a mismatch. Maybe you see that the evidence-based practices you've implemented are not working because they don't fit the population that you have. All sorts of things that you want to keep in mind. And there's a bunch of other resources that I can give you as well. This was, I know, very brief and kind of very broad. So if you have other questions at the end, we can come back and discuss more. Are we holding the questions? We can hold the questions till the end, please. Some references for you guys and contact. All right, thank you.
So Katie and Alexa asked me to come and talk about implementing EBP from kind of a ground perspective. So I'm going to spend a few minutes with you guys doing that. Our system in Colorado has a couple different brains, lots of different brains. Two of them are here with me today, actually. This is Valerie Shamper over here. She works with me in the Division of Criminal Justice. She's involved in the program that I'm going to be kind of representing today, and also Haya is here as well. She's in the back. She's actually a direct service provider of the program that we have funded with our grant. So my job really is to talk about our DOOR program and some of the kind of ground level issues that we face in implementing EBP from the ground. And so in order for me to really do this effectively, I'm going to be talking about implementation on kind of a couple different levels. to really understand our implementation issues at the ground level, you have to kind of understand some of the stuff that comes down from the policy level and the political level for us, because it's very connected, and you'll see what I mean in a few minutes. In Colorado, our EBP culture started in the early 1990s, and it started out legislatively in statute, which really means it started out politically, if you know what I mean. What was happening at the time was that our probation department, which was in the judicial branch of government, and our parole department, which is in the executive branch of government, were fighting. And they were thinking about combining these two agencies into one branch of government, so that caused a lot of fighting. It was known affectionately in Colorado as the probation and parole wars of the late 80s. And so at that time, all these things were happening, and the Chief Justice and the governor sat down and said, all right, let's not do this. Let's not combine these agencies. I got a better idea. They said, we're going to make the state criminal justice agency work together. You know, we had all these different factions of the criminal justice agencies, of probation, parole, the courts, community corrections, institutions, all this kind of stuff. And they said, we're going to make the criminal justice agencies work together, and we're going to make them work on substance abuse. And so what we're going to do, keep in mind this is the early 1990s, they said we're going to standardize treatment for substance abusing offenders. We're going to standardize risk assessment for substance abusing offenders, and in Colorado that turned into standardized risk assessment. We are going to develop sanctions and incentives for substance abusing offenders. That later turned into what we now know as contingency management, although we're still working on implementing that, by the way. But it also put resources into assessment and treatment for substance abuse. It says, and here's a fiscal stream on how to do this. We're going to make you do assessment, we're going to make you work together, we're going to make you collaborate, make you do treatment, and it's all for substance abuse, and here's a funding stream for it. So they forced us to work together, which was a good thing. So keep in mind, at this time, the substance abuse and criminal justice systems are starting to integrate amongst each other and with each other. Then, about 10 years later, the legislature came around and said, hey, we like this. Now we want to do this with mental health. We want the mental health system and the correctional system to work together, and we're going to do that with a standardized mental health screen for offenders. Okay? And Dr. Peters provided you some of those screening instruments. We ended up developing our own, but they said, have to work together, you have to do standardized mental health screening. So that's early 2000s. Then in the mid-2000s, the legislature appointed a criminal justice commission to do some reforms of our correctional practices. This is at a time that we all remember when prisons are growing and the growth rates are swelling and we're dealing with all that kind of stuff. And so that commission that was appointed by the legislature said, we're going to adopt the NIC 8 Principles of Evidence-Based Practice as our paradigm for sentencing policy, corrections policy, reform policy, those types of things. So that brought in the NIC model of EBP in the mid-2000s. And then more recently, legislation was enacted that integrated our substance abuse and mental health system. So keep in mind, early 1990s, substance abuse and corrections is coming together. Late 2000, mental health and corrections is coming together. Now in late 2000s, it takes our state substance abuse agency and our state mental health agency and puts it under one hat and says, now you guys have to collaborate. So, and this is also a time when justice reinvestment starts around, and they start doing sentencing reform that basically says we're going to reduce some criminal penalties, and with the cost savings that we're going to get from that, less offenders go to prison, we're going to put it into dual diagnosis and substance abuse treatment for offenders. So they did this whole justice reinvestment thing of saying prison savings equals treatment dollars. So that really started a lot of the culture that we have in Colorado around implementing evidence-based practice. So the program that I'm representing today is the DOOR program, which is essentially a residential dual diagnosis program for high risk, high needs, substance abusing, dually diagnosed, chronically involved offenders with severe mental illness. And what's interesting about our program is that our offenders are eligible for prison, but they're not eligible for probation. So were it not for this program, these people would be going to prison, because they're not eligible for probation. So you can think of us as a halfway house. Some people call them halfway houses, residential staff secure community corrections program that we do inpatient or residential dual diagnosis treatment for the offenders. So one of the drivers that we thought about was, of course, this whole concept of organizational readiness. How do we know that this organization or this system is ready to implement these practices? And so we really looked at two things. We said, well, we need collaboration. That's a huge important part of implementing EBP for offenders, especially in the world of behavioral health. We needed a site that had a good history of collaboration and a history of expertise of serving this population. So in Jefferson County, Colorado, it's our first judicial district, there was already a relationship intact because of the previous program that we had for offenders that were coming out of prison. There was a strong relationship between the mental health center, the substance abuse provider, and the corrections program that we said that's where we would like to put these resources into because they have a demonstrated history of collaboration and expertise. And just as an example of that, our mental health centers are notoriously, in Colorado, absent in our corrections world. I mean, there's not a lot of incentives for our mental health centers to see offenders. You know, they don't pay, they're butt heads, things like that. And so our mental health centers are not really good about taking offenders in. Well, luckily in this jurisdiction, the CEO of the mental health center was appointed by the governor to be on our statewide Community Corrections Advisory Council. So she actually helps us to set statewide policy direction for community corrections on a statewide level, and she's also involved at the local level with setting policy for the local board for community corrections. So she is actively involved not only on the mental health side, but also on the corrections side. Now, conversely, our correctional director, his name is Greg Kildow, he has a very good, strong history of working with probation, the courts, the substance abuse system, and has the relationships with the mental health center. So it was a good fit for us of finding an organization that was prepared and ready to implement these practices. So this is where integration came in for us to be a challenge. Because, as I had mentioned, to do residential dual diagnosis treatment, you're really integrating systems that are integrating, right? Substance abuse and corrections are integrating since the 90s. Mental health and substance abuse are integrating together. Mental health and corrections are integrating together. And so really putting those into a single program, those parts to make a whole sometimes come with a lot of baggage. So under organizational readiness, one of the things that we were attuned to is really this whole concept of our system vocabulary. Meaning, when you get mental health people and substance abuse people and corrections people at the same table in the same room making a decision for something as simple as, what do we do with this positive UA? You have to have at least an equivalent vocabulary amongst those folks because they all have their expertise in certain areas. So, for example, for the behavioral health folks, we had to train the behavioral health folks to know what R&R was. What does risk mean? What does it not mean? Is it violence? Is it dangerous potential? It's not that. It's likelihood of recidivism, right? To understand what criminogenic needs are, to understand what the R&R principle is, to understand those types of things, to understand that when we have to make a decision to maybe violate somebody for a technical violation or prevent a victim, that's coming from the lens of the criminal justice side of things, or when we're saying we need to address these criminogenic needs, they need to understand what we mean. And then conversely, in the corrections side, we needed to get the staff to understand the difference between Axis 1, Axis 2 stuff, right? Understanding a mood disorder versus a personality disorder, and even understanding something as simple as, you know how corrections folks are. Like, we like to give instructions to offenders. We say, all right, here's what you do. You get a job, you go down to the bus, you take this little pass, you go down to the bus, you catch the 115, you take it to the K, you transfer downtown, you go over there, you go to the job service center, you go over there, your curfew is 5 o'clock, you need to call when you get there, you need to call every time you get around, you need to make sure you come back and check to us, bring all your receipts, come back and check into the facility by 5 o'clock. We give them all these instructions. And then when they don't follow the rules, we write them up, right? What sometimes correctional staff don't understand is that when we give instructions to a person who has cognitive impairments in their brain, and part of their illness is that they have a cognitive impairment, that this part of their brain isn't working to receive all those instructions, that when they come back and they're non-compliant, it's not because they're being a butthead, it's because they're sick, right? So to get the staff to understand things like that motivation as a state is not a trait, that motivation is behavior specific, that it's not on and off. You know, those types of things. So really understanding that system vocabulary is important. We deal with high turnover and undercompensation, I'm sure, much like you all do. In community corrections of Colorado, we're notorious for having high turnover rates. Conference recently, I asked Ed Latessa, hey Ed, you're the community corrections guy from Ohio. I've got high community corrections turnover. What should I do about that to implement EBP? And you know what he told me? He said, you're screwed. He said, you're always going to have high turnover, just deal with it. You're going to have to work with it, not against it. You're always going to have it. And I was like, well, thanks. I appreciate that. So, you know, for us, it's really about getting the staff to discern between illness and criminality, to be able to understand a situation like a positive UA or a rule violation and understand, is that evidence of illness or is that evidence of criminal thinking? And to really learn how to hold offenders accountable for their behavior, but not punish them for being sick, and to have that level of discernment for the staff selection aspect of implementation. Also, role clarification is important. When you're dealing with substance abuse, mental health, and corrections, it's important to, divide the team where the expert is. In a football team, you don't want to have the punter running the ball and having the quarterback catching and having the small guy do the blocking, right? You need to make sure your mental health experts are doing their job, and the substance abuse folks are doing theirs, and the corrections folks are doing theirs. So that's an important part, is having that role clarification about who's doing what. Now, the opposite side of that is conflict, because it creates territory issues. Right? Offender comes to the table and says, all right, we got a guy here with a positive UA. And the corrections guy says, well, I think we need to violate him because he broke the rules. And the mental health person says, well, I think we need to look at his medications. And the substance abuse person says, well, I think we need to maybe up his treatment a little bit, right? Who's the shot caller in that decision, right? So that creates conflict sometimes amongst the team that's involved in this residential care for the offenders. So a lot of times what they have to do is determine who's the shot caller in those situations and embrace healthy conflict. And in our world, I think we all know this, that good healthy conflict is a signature aspect of good team leadership. So if you don't have conflict, maybe you're not collaborating. So that conflict is a good sign that we are collaborating and working forward. So Stephanie talked about fidelity measurement, and which is an issue for us in Colorado, something that we're not fully resourced to do, but things that we are working towards when it gets to the whole piece of quality assurance and fidelity. So one of the things I think that we're notorious for, we meaning probably all of us in this room and us certainly in Colorado, is this whole thing of curriculum salad, right? We like to throw a list of stuff that we do. We do R&R, and we do MI, and CBT, and SSC, and IMDR, and IDDT, and ABC, and XYZ, and contingency management, and all this kind of, we have this list of stuff that we do, right? What we fail to realize sometimes is that the reason how we implement those lists is training and praying. And I know this because I used to be a trainer, right? We say, okay, here's 2 days of learning how to do risk needs assessment. Everybody's gone, you get a certificate that says you're there, and then we pray that they implement it. Then they come back for booster training, and then they lose knowledge. And I say, but I trained you, you should know how to do that. Well, I forgot how to do it because I didn't practice, right? Nobody coached me. Nobody taped me in doing stuff. Nobody recorded my sessions. Nobody gave me feedback on what I was supposed to do. And I say, but I trained you. And they say, well, I forgot, right? So this whole piece about quality assurance is very rigorous and very resource intensive. So what we're resourced to do in Colorado is principally around two of our primary interventions, which is risk needs assessment and motivational interviewing. So without going into too much detail, these two interventions, we do quality assurance in the areas of classroom training. We do some videotaping or audio taping of their skills. We give them structured feedback. There's some live coaching that goes on. There's some phone coaching that goes on. There's actually directed skill practice sessions where they get to play scrimmage with the skills and learn the skills and do the skill practice stuff. And then more coaching and more taping and more feedback and thresholds to meet compliance and those types of things. So we have a few people in our program that are going through both of these cycles of quality assurance. Our challenge is bringing that to scale, meaning everybody in the agency and everybody on all the EBPs, because we have several EBPs that we have on our list. And we don't have the same resources to do this kind of coaching and mentoring and taping and skill practice sessions and thresholds and all this other kind of stuff with our CBT curriculum, our criminal thinking curriculum, or our illness management recovery curriculum, or things like that. Or even we're working on contingency management. We're going to have to figure out quality assurance for that. So when I talked about integration coming with behavioral health and corrections, I talked a little bit about baggage. And so in Colorado, our system is very regulatory heavy. We like state standards, and we like auditing and license reviews, and we like the state to say, here's a whole list of stuff you got to do to comply with the funding requirements. So that's something that our culture likes, right? And so in corrections, we have the state community correction standards. So the provider has to meet all of those standards. And then if you're a behavioral health provider, you have the substance abuse and mental health standards. You have to do these many clinical assessments and this many treatment plans, and you have to meet with them so often and this, and you have to have clinical supervision and all that kind of stuff. And then the corrections side says, well, we got to meet the ACA standards, and we've got local regulatory standards that we have to meet, And then the mental health side says, well, speaking of regulatory standards, we also have our managed service organizations and our behavioral health organizations. We have to meet all those standards. So next thing you know, we've got this system of integrated dual diagnosis treatment that comes with this baggage of lots of regulatory standards. So the folks that are dealing now with implementation science see that and say that's often not a driver for implementation but a suppressor for implementation. That agencies that are very administratively heavy are notorious for poor implementation. So our strategy then is to put evidence-based practice mentality into those standards and to use the power of contracting and law and things to put requirements for evidence-based practice within those standards. So we're really measuring what matters. In other words, now that's not to replace quality assurance, it's not to replace Fidelity, but it's there to say, if we want you to do motivational interviewing, we'll put it in the contract. If we want you to do curriculum-based manualized treatment, we'll put it in the scope of work. If we want you to do a minimum of 200 hours direct therapy contact for high-risk substance abusing offenders, we put it in the contract, right? So we use that power to focus some of those interventions on evidence-based practice implementation. So, and the reality is, honestly, because money is involved, in Colorado, if I had more time, I'd tell you a story about a mental health center that I confronted one time, but they don't like offenders. And so, but when we put money over the hat of the corrections and said, corrections, here's some money, now go out and get treatment from the mental health centers listened. But when you put money on mental health centers and that attracts the corrections people, we go knocking on their doors and they say, well, I don't know if we want your people. There are problems and, we don't know how to break up fights and we don't have handcuffs and stuff like that. But when you put it in the corrections system, the mental health folks listen. And so that was an effective strategy for us, is to put money in the hands of the correctional system. Some other things that we deal with too, and they're smaller problems, but they are logistical and they are issues for implementation, is our population for this program is pretty small. It's an average daily population of about 10 people. Very specialized program, 6 to 8 months, residential, integrated dual diagnosis treatment. Now, this is in the context of a larger 200-bed facility. And that facility has lots of other services that can aim interventions at criminogenic needs. They have a group for vocational and all this other kind of stuff. And so the temptation is to put these 10 offenders in some of these other groups to address their criminogenic needs that aren't addressed in the program. But that rubs up against the responsivity principle to say, are we matching the learning style of severely addicted, chronically ill, highly impacted, high risk, high needs offenders in a vocational group with people that are much higher functioning, lower risk, lower need profile? You know what I mean? If the LSI means something to you, average LSI score for our regular population in community corrections is about a 28. For this program, it's in mid-30s. So their need profiles are different, their risk profiles are different, so we're always tempted to say, put them in that group over there, then we got to think, well, that's not really smart because they're much higher risk and higher need, and I don't know if putting them in with those other folks and addressing their needs, as Dr. Peter said, through a kind of stock curriculum or a canned curriculum is really the right thing to do. So that's a challenge for us. Also, because we adopt group therapy and manualized programs, things that are stock and canned in nature, it really, you can probably ask Kaya of what that does for individualized treatment. It creates additional challenges for individualized care for these offenders to get really into their individual and unique needs. So we've adopted the culture, the thought process that mental illness is not necessarily a risk factor or a need, but really is more of a responsivity factor, that if we can address mental illness, it lets the criminal justice system do its job of assessing risk, targeting needs, enhancing intrinsic motivation, those types of things. So that's kind of how our culture is. But globally speaking, all those issues aside, were it not for these programs, these offenders would be in prison. So dealing with these problems, they're good problems to have, honestly. We really see those as good problems. So the collaboration piece, of course, is very important. Our collaboration spans both public nonprofit levels, at the state level, at the local level. So that's really, really important for us. So in the PowerPoint slides that you have on your USB drive, there's our contact information. This is Valerie, who is here. Aya is also here as well. This is me. So you're free to contact any one of us at any time if you need any information about our programs.
Okay, good afternoon. I'm Amy Seidlitz, and I am the Chief of Offender Classification and Programs for the Washington State Department of Corrections. And over the past several years, our department has been engaged in implementing evidence-based corrections, and we have done many things well, and one of the things that our recent budget crisis has helped us to do is really focus our efforts to fine-tuning the areas where we really need improvement and really looking to be more cost-efficient and cost-effective of how we meet the needs of our population. We have the advantage of the Washington State Institute of Public Policy, and we in addition to our agency, the legislature also has the advantage of guidance from them when identifying how to create a more efficient and effective system. We have turned to the Institute many times to help us to solve problems, dealing with our budget issues, dealing with how to deal with high caseloads, how to bring in services. For those of you not familiar with the Institute, they are a nonpartisan entity that is legislatively directed to conduct research and evaluate research that's out there that really helps us to look at policy issues for our state. They address areas of the whole corrections continuum, the educational continuum, and other areas. I included their website there. If you're not familiar with them, I really suggest you take a look at their work. One of the things that recently happened for us is the legislature asked the Institute to look at what's going on and what's the most effective models within community supervision. With this last budget, there was a high probability that we were going to cut all of community corrections. And so the legislature asked the Institute to do an evaluation of really what's most effective in community corrections. And our agency worked very closely with the legislature and with the Institute to really figure out how could we re-engineer what we're doing to save our community corrections and do the things that we really knew were making a difference. I won't go over all of the findings. There's been some time already spent on the risk needs responsivity model, but the Institute's finding as far as supervision of adult offenders and the effect on crime was that intensive supervision without treatment had no impact on crime. Adding in treatment gave us about a 10%, but using the risk needs responsivity model, we had an impact of about 16%. Looking at these findings and really looking at what were the benefits of allowing supervision to stay within the state really helped us to make our case and re-engineer the way that we do business. One advantage that we already had was the Institute helped us in the development of a risk needs assessment tool. Our entire population had already been assessed, and we'd been using the Institute's cost-benefit analyses and recidivism models to guide our changes over the past several years. There's been a significant investment in training our staff and in implementing the things that we've done. And so there would have been, in the short term, quite a cost to turn supervision over to the counties who hadn't been investing in those practices. I just put up a slide, you probably can't see it, but this is a picture of the Institute's most recent cost-benefit analysis of different programs. This one was just recently published, but they give you an idea of the topic area of programs, the benefits, monetary, taxpayer, non-taxpayer, the cost, and actually the return on your investment. So with these publishings that the Institute puts out, they also do presentations for the legislature and really speak to how they're going to get the best return on their investment on the things that they fund with us as an organization. I think one of the things to note here that was really helpful to us was intensive supervision with surveillance only showed no benefit and actually a negative impact on benefit to the investment, where adding treatment in is where we saw the benefit to our dollars. Some of the other things that have happened over time since 2003 is that in embracing the concepts of the risk need responsivity model, legislative changes have happened. So since 2003, when our caseloads in community supervision were about 65,000, several laws have been passed, and our supervision in the community is right around 17,000. They have eliminated community supervision for most low and moderate risk offenders. The only ones that remain on are being supervised either because they're from out of state and we supervise them through the compact, or because of special sentencing laws that have gone into effect, so drug alternatives and family alternatives, and certain sex offenders. Having that reduction in caseloads has really allowed us to invest our dollars differently and provide services differently. In this last legislative session, one of our commitments was to completely transform the way that we do business without costing any additional money. And so one of the things that we did was propose legislation where we would provide intensive supervision for the higher risk offenders, provide evidence-based treatment, and target treatment dollars to offenders that are high risk to reoffend and have high needs. Since that was always supervised in the community, that helped make our job easier. We have, however, then used grant dollars to focus on some of the offenders that are supervised under our drug alternatives and our family alternatives, where we can focus on those that aren't at the high risk to reoffend. The most significant change that we made with this last legislation was swift and certain behavioral interventions. And what we did here is we had a partnership with the City of Seattle, and we conducted a one-year pilot called the WISP program, which was modeled after Hawaii's HOPE program. And it was a modified version of HOPE, but it still focused on the tenets to reduce drug use, reduce new crimes, and reduce incarceration. Our pilot concluded in February of 2012. We did show good outcomes, but we had a pretty small pilot sample, but we were able to enact legislation for swift and certain. What that did for us was we were spending approximately $40 million a year buying beds from counties for sanction time. So community corrections officers had the option for every violation of supervision for asking through a hearing for up to 60 days in jail per violation. With the changes in this model, community corrections officers for low-level violations don't have to go through a hearing and can give offenders up to 3 days in jail. They can use their discretion there to determine if they're going to impact their availability into treatment, their accessibility to services or employment. One of the things that we found was by putting people into jail for sanctioning, we cut off their availability and their funding for treatment, and we had to start the process all over again. And it was actually impeding our ability to address mental health and substance use issues. So there is still the option for higher level violations to go through a hearing process, but the maximum amount of jail time that anyone can serve is 30 days. We used WISP's recidivism model and looked at the savings and we anticipate a significant reduction in recidivism, and we were able to convince the legislature to allow us to keep the majority of the funding as long as we invested it in cognitive behavioral treatment for higher risk offenders, mental health treatment services in the local communities, and both residential and outpatient chemical dependency treatment. That was a significant just accomplishment for us to be able to do that in times where every other place across our state was hearing budget cuts. So for us to be able to keep that money and invest that was a key thing. One of the major things that happened through our legislature, though, was their interest in us investing locally and ensuring that not only are the services available for our offenders as they transition out, but we create local resources for prevention services as well. So as we're furthering our efforts towards evidence-based corrections, we continue to provide cognitive behavioral interventions to high-risk offenders. We are focusing on the best ways to identify and address barriers to involvement in risk reduction activities and connect offenders to services and positive social networks. one piece, along with the swift and certain, we've been teaching our staff core correctional practices and teaching them how to do positive reinforcement as well as negative reinforcement. And we have also trained, are in process of training our community corrections staff and prison staff in motivational interviewing. Ensuring all aspects of our model are administered with fidelity is a new aspect within the last year in our agency. We've had bits and pieces of quality assurance, but it really has not been a primary focus. So we've established a quality assurance unit. All of our contracts where we contract with folks to provide us training involves a 4-year process where they bring and measure our staff to competency. They come on site, provide the coaching and mentoring, that they actually do video or audio taping over a series of time to ensure that we have fidelity. And we have 10 dedicated quality assurance specialists right now, 5 for prisons and 5 for community, who also go out and help oversee those practices. Some of the barriers that we are really focusing on addressing is our homelessness. We have instituted a housing voucher program, so we have offenders who are eligible for release from prison and have nowhere to live. The majority of those we're finding are sex offenders and those that are mentally ill. So we've established a housing voucher program and services in the community where we pay for housing that offers both residential and treatment services for up to 90 days while we're working to find local services to connect them to. Mental illness has been a great barrier. One of the challenges in our system is, in order to cut costs, we focused our internal resources only on those that met the threshold of seriously mentally ill. And so those with Axis 2 and that didn't quite meet the threshold just got crisis stabilization and not a lot of other services. So we're taking this investment money and reinvesting it in that population to assist with their services in transition as well. Addiction services, with the benefit we've had from the drug offender sentencing alternative, it's been a plus. There's been focus on it. People have had shorter prison terms, had more time in the community, have gotten connected to community resources. However, how the services got prioritized was to all of those offenders. And they didn't necessarily turn out to be those high-risk, high-need offenders according to our assessments. So we are expanding with that reinvestment money our treatment services so that we expand our prison treatment and our post-prison treatment. And lack of employment has been a key issue. We have focused on providing vocational training, educational training in our prisons, where one of the chief measures was just how many certificates someone got or how many hours someone completed. And we really have changed our measures now towards how many people actually got jobs in the areas that we've trained them in. And just paying attention to that has significantly changed the way we do our business, the resources that we provide. We've invested in a database that shows who's hiring, and offenders can leave now with a portfolio of who's hiring in the areas that they've been trained in. And we're really now problem solving because we have better data to look at how we provide more services in that area. These tables, I see them and you probably can't see them very well, but the other part that we've been doing is really focusing on being much more proactive in how we invest our funding at an organizational level. The table on the left is the results of our risk and needs assessment for our field population. The one on the right is the same for our prison population. So what we're looking at for our population as a whole is what are our percentages of high risk to reoffend and what are our percentages of needs in specific areas. And we are now changing our organizational practices so we invest our dollars commensurate with those percentages. That has not been the practice in the past. That's also been a significant struggle for some of our partners that we have contracted with in the past. And so we have had also the benefit of the Institute of Public Policy coming out with us, doing shared workshops on evidence-based practices and helping to identify areas where those that we've contracted in the past and what we've funded before, what are different things that they could offer to continue to partner with us. Our other thing that we've been doing to really help project where needs are and identify our contracting is using the prior tools and doing a mapping and sharing the mapping with the counties that we contract with. So this particular map shows by county, by population, where our offenders are and who meets our criteria for funding for cognitive behavioral treatment, CD services, and mental health services, actually by number. And we can look at this not only by our present population, but by those that are releasing, say within the next 18 months or 24 months, to really target our funding different and put our contracts out knowing the numbers in the population that we're hoping to have served. Our demographics right now, we have between 13 and 18.7% of our seriously mentally ill in our prisons, nearly double that for our female population. We offer 574 residential treatment unit beds for men, 33 for women, and about 50 work release beds that are co-ed. The gaps that we've noticed are those that don't meet the threshold of seriously mentally ill aren't really currently eligible for mental health services in prison and have challenges connecting in the community. Our staff lack the knowledge of really how to recognize those offenders that have those service needs and how to connect them to services in the community. And we have found very few available residential treatment services for the mentally ill. So some of the things that we've been doing to address that, we've partnered with some local mental health crisis teams to deliver training to our staff on how to access the mental health crisis services. We've also been sponsoring Corrections and Mental Health Track at our statewide behavioral health care conferences. 2010-11, we'll do it again this year in June, and we sponsor up to 42 staff across divisional to help gain their understanding of our behavioral health population. Our biggest things in progress right now is our system is really geared towards the high risk, high need, and the cognitive behavioral, and we have this gap with those that don't meet our seriously mentally ill threshold. So we are now focusing on our population with mental illness and co-occurring substance disorder who aren't eligible for Medicaid. Because those, when we take them out to the community, we have just the most challenge of connecting them to services. So we're focusing on getting providers to come to our facilities to meet with them before they release, and then helping to get them connected upon their release. All of them have a reentry plan. We're developing a resource directory and training our staff to work with that population. In addition, we provide the population who meets the criteria a TC type substance treatment program pre and post incarceration. And the next steps where we're at are assessing our assessment tools to really determine if they assess the risks of our female offenders. We're finding that they're not really fine-tuned enough to really help us to identify the service needs as much as we'd like for that population to adequately inform our practices and to help us to measure the right changes over time. We are training staff who work with our eligible population in motivational interviewing, the EPICS training, and core correctional practices. As I said, we added a quality assurance unit, and one of the key things there is that while we have dedicated quality assurance staff, we've changed the position descriptions of all staff so that they all have a role in quality assurance, and the specialists are spending their time coaching and mentoring and training the supervisors and managers so that they can carry on the practices. And that's, I say for my minute? Okay.